Good day, everyone. This is Steve Anderson, and welcome to our Crown Council webinar today, Insurance Coding Mistakes, what you need to know today for maximum reimbursement in 2018. We're going to start here in about 2 minutes. So as you're getting settled, just wanted to give you a couple of housekeeping items and some instructions as well as some announcements. So if you've never joined us before, you are in listen-only mode. That means you should be able to hear us loud and clear. We cannot hear you. That's in order to minimize background noise. So if any time you have any questions in your control panel on your computer screen, there is a question area. If you just look down all the list of pull downs, you can click on the question arrow, and at any time you're welcome to submit a question. We'll answer questions at the end of the formal presentation. So you're very welcome to submit those questions at any time during the presentation, and then we'll get to those. We're going to run approximately an hour today. We've got a packed webinar with a lot of content. This is not a webinar for casual in the background observing. Be good to have paper and pen ready to take notes. We are recording the webinar. It will be posted on crowncouncil.org later today for team members that weren't able to attend, and we'll send out an email notification to the Crown Council list as well as everyone who is registered so that you have a link for that webinar. A couple of just housekeeping, just a couple of announcements. We're very excited to launch the 2018 Smiles for Life campaign. As you know, last year we went over the $40 million mark in terms of total money raised, and we're now looking forward to making a big leap forward this year again. All of the marketing materials are being shipped from the Crown Council office to your office. They will leave the Crown Council office on January 30th. If you have not signed up for the Smiles for Life campaign and would like to participate this year, today is the day to sign up so that you don't miss any of the materials or any of the campaign resources. You can do that by calling the Crown Council office at 800-276-9658. So that's 800 Crown 58, 800-276-9658. The Smiles for Life campaign, the largest charitable campaign in dentistry, launches March 1st. Ultradent, who generously supplies all of the whitening kits, has committed that those whitening kits will be in your office ready to go by March 1st. So keep an eye out for that. Again, if you haven't signed up and want to participate in this year's campaign, give the Crown Council office a call today and make sure you get signed up and participate in the most widespread successful charity campaign in dentistry. With that, we are excited about the webinar today. This topic that we do every year when the new insurance codes come up is one that always engenders a lot of interest because everyone wants to make sure they stay on top of what's going on so you can get maximum reimbursement for what you do. Joining me today is Pam Peterson, and most all of you know Pam Peterson. So Pam is the president of the Total Patient Service Institute and leads our whole team there of practice advisors. Total Patient Service Institute has an army of specialists, practice management specialists out in the field every day, and some of them are in your practice today, working on implementing the highest level of patient service skills, case acceptance skills in practices all over the country. Pam is our topic expert today. And I, of course, am going to add some color commentary and some additional thoughts in terms of insurance being contracted versus being insurance-free. I'll talk a little bit today about fraud and embezzlement, as well as some verbal skills that you can use to get better acceptance. So Pam, welcome, and thanks for being our topic expert today.
Thanks, Steve. I'm excited to be here.
We'll let you take it away.
All right. Well, I'm excited to talk about codes and things that are new for 2018, things that are old. It helps me as well. So we're going to just jump right in and talk about the first primary codes that we're pretty familiar with. So Steve, you want to advance the next slide? So many of you know about the D4910, D1110. Some policies provide reimbursement for two 4910s and two 1110s during a 12-month period. Even though insurance reimbursement frequency may be less than what is recommended by the dentist, we must report the correct procedure. So in the event that a 4910 is not covered, we may request an alternative benefit payment for a D1110 to be applied to D4910. My rule of thumb is little payment is better than zero. And it's a good thing to make sure that we code and we submit all of the great work that our fantastic hygienists perform. Okay, next slide, Steve.
So just for clarity on that, Pam, one of the things we run across a lot is a team will submit a claim, and they'll alternate. One time they'll do a 4910, and the next time they'll do an 1110, and the excuse is, well, the insurance won't cover 4 4910s a year. So bottom line here is you always code it a 4910, and then in the narrative, you'll just add, if 4910 is not allowed, please use the alternate 1110. And then
Absolutely.
That way you're coding it for what you're actually doing, and you let the insurance company change the code, not you.
Absolutely. And you won't receive what you don't ask for. So
you got it.
For clarifying that, Steve. All right, so let's talk about exam codes. There are three that we're familiar with. The first one is 0120, which is established patients. It's a periodic exam. The D0140 is the limited exam, and we use that for problem focus. And then the last one, D0150, a comprehensive exam for established patients or new patients. So established patients, most of the time we are not using this for established patients. If you have a patient that have been absent from active treatment for 3 or more years, you can use a D0150 comprehensive exam code. So it's not just for new patients. Now let's talk about 3 codes that we forget about and they stay in the background. So we're going to talk about D0160 first. Next slide, Steve. The D0160 is a detailed and extensive oral evaluation problem-focused code. It's mainly for a second evaluation. Many times when patients present themselves when you see them as a D0150, a comprehensive exam, or a D0180 for a comprehensive periodontal oral evaluation, there's a lot of information to go over. And there are times when the doctor needs to see the patient for a second appointment. You may use the D0160 for a second evaluation after the D0150 or the D0180 has been performed. This is to further evaluate a previously discovered condition. Next slide, Steve. The second code is D0170. This is a reevaluation of an established patient for a specific problem in which a definitive treatment has not been rendered. Many patients, a doctor will ask them to come back if they need to monitor abnormal soft tissue or if the patient is still in pain and it hasn't quite been diagnosed. Many times when the patient comes back, we will code it as a look-see code, almost a generic code for no payment. Well, a D0170, this code is for reevaluation of an established patient for a specific problem where the doctor has already had a D140, which is a limited exam. You may code out a D0170, which is a reevaluation. So those are 2 codes that are often missed. The final one is the D0180. D0180 may be reported when performing a comprehensive periodontal evaluation on qualified patients who show signs or symptoms of periodontal disease. Also, if they have risk factors, like if they smoke or have diabetes. Now, the D0180 It's a standalone code, and it cannot be used with a D0150. So it's either or. So if you have a patient that's a qualified patient that shows signs and symptoms of periodontal disease, you may use this periodontal code, which is the D0180. Next slide, Steve. All right, there's a couple of codes that many of us use. These are two PA codes. Next slide, Steve. So these two PA codes are D2950, D2949. We use these codes, and we use them a lot. The D0220 and the D0230. These are the two PA codes that we use often. The D0220 is a PA code that's coded out as the first PA. The second, which is the D0230, this is for an additional PA. Both may be charged out. One is for the first PA, the second is if you need an additional PA. And how these are used in the practice, if the doctor requires for a yearly endo check or an implant check, or if you need a pre or post-operative PA for a crown. Sometimes one is not enough. So there's a code for the first PA, and then there's a code for the second PA. Next slide, Steve. All right, this is the code that I was dying to get to. These are our buildup codes. The first one is the D2950. The second one is the D2940. We work with many practices that will use one or the other and not both. There is a difference in the two codes. The first one, the D2950, is a core buildup used for retention of the crown. A narrative should always be presented when using this code to identify the actual percentage of the missing tooth structure. Some payers require 50% or more of the tooth structure to be missing before rendering payment on the D2950. The D2949 is, the D2949 is to be used when it is to replace the inside of the tooth. So this is normally used for a crown bridge, inlay, or onlay. It's unlikely that the D2949 will be reimbursed. Most payers will determine that the D2949 is part of the reimbursement provided for the indirect restoration. And I know many of us have experienced that, where you'll get no payments because they feel like the D2949 should be part of the crown. So if they feel that it's part of the crown and we use the D2949, it's rare that you'll receive payment on the D2949.
All right, time to say goodbye. I think there's a famous song by this name. Thought we'd just take just a moment to address all the changes that are taking place, especially with Delta Dental. Many of you know they're doing away with Delta Premier in most parts of the country. That is impacting a lot of people who are just providers for that specific service. So we're fielding a lot of questions and a lot of calls around practice's status with insurance. What should we do? Should we be a provider, not be a provider? A lot of decisions that are having to be made. So if I could just give you a quick list of questions that you should be asked. I'm not going to solve your problem today. I'm just going to give you some questions that you need to ask as a team before you make any changes in terms of your status as whether you're a provider or not a provider for any insurance. So here's the list. One, what percentage of your patient base has insurance? So what percentage of your patient base has, for example, if you are a contracted provider, then what percentage of your patient base has their insurance benefits with the company that you're contracted with? So that percentage can give you an indication of what direction, what steps you need to take if you're going to make a decision in any different direction. You need to have a real clear handle on that. Second, what's your marketing budget? So I'll just give you some rough numbers. For example, a practice that is contracted will spend up to about 4% of revenues on marketing. Totally fee-for-service practices, we find, will spend 10% or more of practice revenues on marketing. So If you're going to be totally fee for service, you can plan on spending more on marketing. Generally, again, these are general rules. Make your decision way in advance. So if you're going to make any changes in terms of your status as a provider, you need to make that decision at least 6 months in advance, because you want to have a face-to-face conversation with the patients that will be affected. You do not want to send them a letter informing them of the change, because it just gives them an opportunity to to make a decision. So it's face-to-face conversation with specific things that you'll say to increase your retention. Next is you want to make sure you maximize your reimbursement in your coding, whether you're contracted or not. Your patients with insurance are going to want to get the most from their insurance benefits. So you want to make sure that house is in order. On almost a daily basis, we have the team at Total Patient Services out helping practices maximize their reimbursement from coding. That is a specific service actually that's provided. Improve your verbal skills. Talking about patients' insurance concerns and their benefits is a highly skilled technique. You can't leave it to chance. A lot of these conversations need to be scripted out, and I'm going to give you some examples of those today. Seventh area is you take a look at expanding the services that you provide. Take a look at things you don't do that you might want to add to your procedure mix moving forward, and also broaden your payment options. For example, we recommend that a practice have at least 3 forms of third-party financing available for their patients. 3 forms of third-party financing. So the more financial options that your patients have, the more likely it is that they will be able to make financial arrangements for treatment. So that's just a quick list. In a future webinar that will be coming up in the next 30 days, we are going to do an entire webinar just on going insurance free, or the questions and the analysis you need to do to make that decision. So keep your eyes open for that. That's coming up here in the next 30 days. All right, Pam, back to you on narrative secrets.
Got it. Thanks, Steve. All right, so I know we're talking about coding. We also want to talk about reimbursement, whether you take insurance assignment of benefits or your fee for service. If you file insurance for patients regardless, we want to talk about some secrets and ways to increase your reimbursement. There are a few suggestions that I want to include. All right, first, I want to let you know that narrative writing process, it may take a lot of time, but when you receive reimbursement after the first submission, you'll get excited about it. And so let's talk about a few symptoms that you want to make sure that to avoid or to start doing. Any symptoms a patient is experiencing and the amount of time those symptoms have been present. You want to include that when writing your narrative.
Sorry about the.
No worries.
Sure. There you go.
All right. Also, when customizing and writing your narrative, you want to make sure that the location and the amount of existing is listed. Next. The amount of any remaining healthy tooth structure. If there's an existing restoration, the condition of the restoration, and the surfaces involved. If any part of the tooth restoration is fractured or missing a cusp. If the cusp is fractured, fractured off, missing, or severely undermined. If the tooth has a cracked tooth syndrome, and how did the doctor diagnose it? Last but not least, remember the clinical record must include the same information provided to the payer that's in the narrative. Now, what we just went over, these are examples of what to use and what to include when you're customizing your narrative. A few more that will improve your claims that are listed on the screen is avoid a narrative checklist. Sometimes when we have a narrative checklist, we miss a step and we just cut and paste. It's the same thing for electronic narratives. Customized narratives are the best. Generic narratives decrease approval. What I mean by custom narratives is I gave a list of specific information that you want to include when creating a narrative for your practice. You also want to be precise in describing clinical facts, include the diagnosis for procedures exclude subjective remarks. To improve your claims, never include anything that's not documented in the clinical chart. We can't say that enough. Use proper spelling and punctuation and grammar, and I know many of you are seeing that as a no-brainer.
Cam, you're starting to sound like my grade school English teacher.
Using proper spelling and punctuation and grammar, I know. Don't mean to, but if it's on this screen, then it's safe to say that it's happened before.
Oh yeah, well, but it decreases credibility if it's not
Absolutely
100% correct.
Absolutely. You also want to avoid handwritten narratives to ensure that everything's legible on the claim. When a claim expert is looking at your claim, and if there's anything that they have to work hard by trying to understand or decipher, it goes to a pile of a black hole, which means no one ever gets to that pile. And so you're having to call them to figure out what happened to your claim. The last one you want is to omit irrelevant or unnecessary comments on the claim. Now I'm really going to
All right, here comes Miss Etiquette. Miss Etiquette is now arriving on the scene. Everyone sit up straight and mind your manners here. Here we go.
I know now I'm really going to sound like your teacher. You want to make sure you never use aggressive language, statements, or challenge the expertise of the consultant or components of the plan. And I know that that's a no-brainer because everybody that's listening on the call are Eagles, because they all know that you get more bees with honey. The last one, you want to include clear diagnostic quality radiographs. Never send originals. Always properly label the radiograph image left or right. I know that the specialist knows left or right, but you want to make it easy for them to say yes to your claim so that you receive reimbursement pretty quickly. All right, Steve, let's talk about time management. The business team members, we know you have multiple plates, not multiple, probably many plates juggling. Well, we have our favorite acronym that we use, which is OHIO, only handle it once. Take time to do it right the first time so that it affords you to do all the great things that you enjoy doing within the practice. So let's talk about a couple of things that will help with OHIO. The first is you want to make sure that the insurance claim is completely filled out. Do it right the first time. You want to make sure that correct procedures are listed on the claim. Next. You want to make sure that the claim file submitted within 24 hours, the same day. You want to make sure that the correct documentation is sent with the claim. If you know that a perio chart is needed, or a full mouth series, or a PA, make sure that you practice OHIO. Send it the first time. You also want to review claim submission status. Now that one's really important. You want to make sure that you have a clear understanding of the steps for electronic claim submission. Occasionally there's a glitch, so don't ignore if you receive an error message. You want to make sure that your claim goes all the way to the clearinghouse. You are not in the clear until your claim hits the clearinghouse. There are 3 reports. It doesn't matter what software you use in your practice. These reports will give you the same information even if they have different names. The first report you want to check, and the keyword is daily, is insurance claims not sent. The second, procedures not attached to insurance. The third, secondary insurance claims not sent. These 3 reports should be checked daily. Now, when you check these 3 reports and they're blank, give yourself a big hand, because that is good business, making sure that these 3 reports are checked daily and that they're always blank. Next. All right, last but not least, you want to make sure that you trust but verify. We're all responsible, but there needs to be one accountable person. Assign an accountable person that will follow up on claims that are not paid weekly versus monthly. Monthly is old school. Many years ago, we would follow up on claims by the 15th or maybe the 25th. Follow up weekly and have a relationship. Pick up the phone. Every time you hit resubmit without research, it costs the practice money. So please pick up the phone and call and find out what's the delay in reimbursement on the claims that you submitted.
Perfect. All right, so speaking of mistakes, since that's the topic of the webinar today, I'm going to take a few minutes to talk about fraud and things that you can do to make sure you don't make fraudulent or mistakes that could be construed as insurance fraud. So take very close attention to what I'm about to say next. This is based on experience of practices we've worked with in the past, many of which had no intention of doing anything wrong, but because they weren't doing things right, then they ran into some trouble. So before I get to my fraud list, let me give you one suggestion, since we're at the beginning of the year, on the whole just maximizing reimbursement. This almost goes without saying, and occasionally we run across a practice where they just overlooked this and didn't do it, which is in January every year, and sometimes in July, depending on the insurance, is you need to make absolutely sure that you update your fee schedules in your system. So if you're contracted, for example, you want to make sure that all of the correct fee schedules are updated in your computer system. We also highly recommend that at least once a year, you do a fee schedule analysis on your fee-for-service fees. So there's a great resource that we provide at the Crown Council where you can just send in your zip code where your office is located, and in return, you'll receive a spreadsheet of all of the fees by procedure code and what the different fees are that are being charged in your area so that you can see where your fees land, and then you can set your fees accordingly, whether you want them to be in the 80th percentile for your market or the 50th percentile, but it's a way of calibrating your fee-for-service fees so that they're in line with what's going on in your market. So update your usual and customary fees every year. We'll give you a resource for that before we finish today. And then if you're contracted, make absolutely sure that all of your contracted fees are updated in your system so that things are being billed out correctly. Fraud, let's talk about just some specific things that you want to keep an eye on. One, we run across this occasionally, practices that will just write off the patient portion. So in Texas, this is what we call the good old boy dentist. Which says to his buddy, he says, yeah, just come on in and whatever your insurance pays, that's what we'll take and we won't charge you anything. Well, that's fraud. So in every insurance agreement, provider agreement that we know of, you are required to collect the patient portion. And if you write that off and do not disclose it, that is considered insurance fraud. So that we run across that occasionally. If I've hit a sensitive nerve, that's my job here, is to raise the warning is you're taking a huge risk. If you write off the patient portion and you do not disclose it to the insurance company, you are committing fraud and potentially could be liable for that. Next is billing procedures that are not completed. So for everything that gets submitted, you have to absolutely make sure that the procedure has been completed and done all the way through to the end of treatment. If you're going to bill for it, you have to have done the treatment. That seems like pretty basic common sense, and occasionally we run across situations where that has not happened. Next is charging less or different than what you filed for. So most insurance companies require that if you're charging a fee less than the contracted fee, that has to be disclosed when you file the claim. So if you're charging it out any different than what you're telling the insurance company, that is fraud. So it has to be consistent. Whatever you're actually charging is what needs to be on the claim. So those are the don'ts. The one other thing that I would suggest, and just as a reminder, in chart notes, in your clinical notes, just a quick reminder is you can't go back and change your notes. This is something we run across occasionally. So once the clinical notes are entered, they are entered. They are not to be edited. if there's any changes that need to be made, then you update the clinical chart notes, but you never go back and edit them. So if there's anything that you need to add, go ahead and make an additional note, but never go back. If you go back and edit, then that can be considered fraud as well. So that's just a short list. There is a much longer list, obviously, but those are ones that we find on a pretty regular basis. Every once in a while we'll find those. So just reminders, stay very far away from those mistakes. All right, Pam, new insurance codes for 2018. So we've just started a new year. Every year there's new codes that come out or ones that are changed, and some matter, some don't. So walk us through the changes.
All right, perfect. Thank you, Steve. So we're going to talk about 3 denture codes that have been deleted, and they've been deleted because they do not follow the standard that will indicate complete or partial denture. The 3 codes that were deleted are 5510, 5610, 5620. So let's talk about D5510 first, which has been deleted. It's replaced with D5511. D5511 is to repair a broken complete denture base, mandibular. The D5512 repair broken complete denture base, maxillary, so the lower and the upper. Next slide, Steve. D5610 was deleted. It's been replaced with D5611. So D5611 is to repair.
Did I just do this? Did I just do this? Is this a repeat? I think this is a repeat.
Okay.
I just did this. I'm sorry.
It keeps going.
There's the next.
Right. I'll wait for you to stop. You ready? Got it. All right. So D5620. D5620 has been deleted, and it's replaced with D5621. D5621 is to repair cast partial framework, mandibular, and the maxillary, which is the upper, is D5622, repair cast partial framework. So those are the 3 deleted denture codes. Next slide, Steve. Currently, there is no code available to report implant screw removal. The only code that we had was to repair. The new code is D6096, to remove broken implant retaining screw. So I was excited about that. Next slide. D6118, implant abutment supported interim fixed denture for a dentulous arch, mandibular. This is to be used when a healing is necessary prior to fabrication, placement of a permanent denture. That's for the mandibular, the lower. The upper is D6119, implant abutment supported interim fixed denture for the upper. Now the interim denture, and I know that all of you know this, but I wanted to clarify, this is intended for healing purposes only, and it's limited wear, not permanent. Now reimbursement is limited, so in most cases the patient will be responsible for the cost. So if you need verbal skills with that, we can help you with that, but most of the time the patient is responsible for the cost.
All right, verbal skills time. As everybody knows, dealing with insurance concerns that patients have requires a high degree of verbal skills expertise. So just a couple of reminders, I'm going to share with you some suggestions, best practices on how to address this question from patients: do you take my insurance, especially if you don't? So if you're not a contracted provider for a particular insurance plan, then if you're not careful, the common response is no or not. And the moment you say no, then the conversation has ended. So now I want you to think, as we talk about this, how many of you have patients who have insurance benefits with a company with which you are not contracted? Okay, so they have benefits, but you're not contracted with that company. And I would venture to say that everyone listening has patients like that. So insurance wasn't necessarily their #1 consideration. So how do you increase your odds of gaining and retaining patients if you don't happen to take their insurance? All right, so the first response to this question, especially if it's on the phone, is to respond with a question by asking, what insurance benefits do you have, or with which company are your benefits? Okay, so you're going to respond to the question with a question. Then here is a suggested response. And one of the things I'll just say here is that you can only respond this way if it's true. Tell the truth. It's always a good idea. So let's say that they have benefits with a company that you're not contracted with, and you have patients that do have those benefits. So Pam, if you're the patient, I might say, well, Ms. Peterson, you're in luck. We have a lot of patients that have those same benefits. So you're in good company. We don't happen to be contracted with that company because we are an unrestricted provider. Keyword. And what that means is that we can work with just about any type of insurance benefits. Okay, so there's some key, I'm not done yet, but this is the key to that beginning. Let me just highlight a couple of things. One, the first response after you ask them who their benefits are with, then is to say we have a lot of patients with those same benefits, okay? Only if it's true. But the point is to let them know they're not alone, okay? So that they're in good company, there's other people just like them that come to your practice. Then, in the spirit of full disclosure, to say, we don't happen to be contracted with that company because we are an unrestricted provider, which means we can work with just about any type of insurance, which you can, okay? So you can file any kind of benefits. Now, obviously, this wouldn't apply if it's, like Medicaid benefits and you're not a Medicaid provider and Medicaid won't, reimburse anybody unless they're a Medicaid provider. Obviously, there's some exceptions to this. I'm talking about the vast majority of cases, okay? So keywords, I put in green, a lot of patients, they have the same benefits, you're an unrestricted provider, you can work with any type of insurance, okay? So all those are key, very key words. And then comes the question, would you like to know why our patients with your benefits, Pam, choose our practice?
And of course I would say yes.
Of course you would say yes. We have yet to find a patient who says, no, I don't want to know. Don't want to know why. Of course they're going to want to know. Okay, right. So we're keeping them engaged. And then the next piece is to say, well, Pam, what they tell us, what our patients with your benefits tell us is that when they go out and look, they're not able to find the quality of care and the high level of patient service that we offer in our practice anywhere else, okay? And again, this has to be true, but there's a reason that those patients come to your practice when they could go to another practice that is contracted. So ask them why they come, and then you share that information with your other patients who have those same benefits. So what they tell us is that they're not able to find the type of quality of care and patient service that we offer here. They're not able to find that anywhere else. And then in addition to that, we help all of our patients maximize their benefits by filing their claims for them. So we can help you with their claims so that you get the benefit of your insurance coverage. So Pam, would a Monday or a Wednesday appointment work best for you? So I'm going to do the explanation, and then I'm going to go right in and ask for the appointment. Okay, so let me just make a note. I've gone through that slow enough. Hopefully you're able to write those down. I'm not a big fan of scripts. In other words, having a word for word script that you recite. What I am a big fan of in many cases like this, where the stakes are high and there's you have to know how to handle it in a specific way. Sometimes you need to borrow someone else's words and make them your own. So taking this dialogue, committing it to memory and owning it so that it flows out of you as if you're saying it for the first time to someone else, very conversational. So there are some keywords in that dialogue that are absolutely golden that we have tested and tried in practices all over the country that you might want to seriously consider committing to memory and making them your own. Okay, so that's a suggestion just in that area for dealing with patients who have insurance that you may not be contracted with. All right, next is the question, will my insurance cover all of this? So this is either a chair side discussion or a financial arrangements discussion, right? So this one merits some clarification. So how we like to respond to this one is with a question to say, it sounds like you want to maximize your benefits so you can minimize your portion. Am I right? So it's a clarification question to say, it sounds like you want to maximize your benefits so you can minimize your portion. Am I on track? Am I right there? Usually they'll say yes. Okay, so then you can walk through and you can say, okay, based on what we know about your insurance benefits, here's your insurance savings. This is the next verbal skills suggestion. Don't ever say your insurance will only cover this much. Instead, you're going to say your insurance savings. So the fee for the work that we've talked about today is X. Your insurance savings are this amount, which leaves your portion. Okay, so we're going to do away with the often commonly used phrase, you're out of pocket. Okay, so I don't want to use that. I want to use instead your portion. Okay, so these are, again, trigger terms that can make a difference in the outcome that you get with the patient. So the fee for the work we've talked about is X, your insurance savings is Y, which leaves your portion as whatever the remaining portion is. Does that make sense? Okay, so hopefully that gives you some verbal skills suggestions on how to deal. Just again, beginning, there's a lot of insurance related verbal skills that merit some close study. Those are two of them that we suggest. All right, Pam, we're going to jump into questions.
Okay.
And before we do, let me just mention a resource. There's a couple of different resources that go along with our topic today. One is many are familiar with the Coding with Confidence resources. Dr. Charles Blair, who for many years has kept the industry updated on insurance changes and proper coding. So there's a lot of great insurance related resources at practicebooster.com. And I interact with Dr. Blair on a regular basis. In fact, he emailed me this week with some updates and some suggestions. So there are some great resources there at practicebooster.com, including their annual Coding with Confidence manuals that they publish that have all the latest insurance changes and updates and suggestions based on how insurance is being used today. So that's one resource. Next is, I mentioned earlier in the webinar, if you'd like a fee analysis for your practice, specifically for your zip code, just email your zip code to Spencer at crowncouncil.com. Spencer Chipping on the Crown Council team will run the fee analysis for your zip code, send that back to you, as well as can schedule a time with you to go over that and explain it. There's a lot of data there, but it can help you adjust your fee schedule each year based on what's going on in your marketplace. And then finally, verbal skills, which is a constant body of work, something that the Total Patient Service Institute specializes in, helping teams maximize their verbal skills effectiveness. There's a great free special report, a ebook entitled Why Case Presentations Fail, that has some good insurance-related verbal skills. You can access that and download it at totalpatientservice.com and just go to the free resources tab, and you'll find that ebook available for download. All right, Pam, questions. Got quite a few here, so let's tackle these and in order that they were submitted. So let's talk about the exam codes for starters. We talked about those at the beginning of the webinar. The question is, don't all these exam codes share a frequency? So if a patient has to come back after the comprehensive exam for a secondary exam, you've used all of their exams for the entire calendar year. So in other words, can you only use a certain number of exam codes per year? So we're talking about using different codes during the year. We're talking about choosing the right code to use when they do come in for their exam.
Okay, that's a great Great question, Sharon. Yes, there is a frequency with all of them. And just like with all the other codes, you need to make sure that you get a breakdown of insurance benefits prior to presenting to patients. Now, the D0160 for the second evaluation, there are some payers that will pay once a year, some twice a year, in addition to the D150 or the periodontal code, which is the D0180. But you must make sure that you get a breakdown of benefits whenever you call insurance to find out what their coverage is. So some is once a year and some is twice a year, in addition to the D150. And that's the D0160, which is the second evaluation appointment code.
Got it. Next question. Why would you use the D2949 if it will be included in the cost of the restoration? That's just an inevitable write-off. So I guess that's the question. Why would you code it if it's probably not going to be covered?
Well, so if I just go black and white, which is the CDT code, to explain the difference in the buildup codes, one buildup is not to replace missing tooth structure. It's to fill a void. When a patient has endo, there may be an occlusal hole, and the D2949 is really not covering tooth structure or to help with retention. We have many that won't use D2949, but if I were just to read from the CDT code exactly what they are, that's the difference. The D2949 insurance has decided that it should be part of the restoration because it's inside of the tooth as opposed to helping for retention.
Got it. Perfect. Next question. We talked about financial arrangements, and one of the recommendations that we made was that you have at least 3 forms of third-party financing available for your patients. So the question is, we use Care Credit and Lending Club. What else is there that you recommend? So I'll answer this one if that's okay. We keep the kind of an update on all of the third-party lending resources. We update that several times a year at the Crown Council. So you're welcome to email, again, Spencer@crowncouncil.com when you email him for your fee schedule analysis. You're welcome just to include in that email, just ask him to please include the third-party finance resource list. Third-party finance resource list, and he will send you the most updated resource list that we have researched. It is fairly comprehensive. It may not include everything, but it will include the most widely used forms of third-party financing in dentistry. So if you're on the hunt for a second or a third resource, that would be a good report to request, and he'll send that out to you. Next question that has to do with fraud. What about giving a discount on the patient's portion? Is that fraud? So Pam, you can weigh in on this. My understanding is that part of the agreement that you have if you are a contracted provider is that you will collect the patient copay. That's part of the total fee. And that if you collect anything less than the copay, if the copay is $50 and you say we're only going to collect, we'll only charge you $25 or $10 or whatever, that has to be disclosed or it is insurance fraud. Am I correct?
Yes, 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 absolutely.
So you have to collect the whole thing, and if you don't, you have to disclose that. Next question, is it okay to write off the patient portion if we are not contracted with insurance? Pam, your comments on that?
Only if they are the doctor's family. I'm just kidding. Is it okay to write off? The doctor can always make the decision who he or she would like to charge. What we're going over is an agreement that you make with the carrier. If your guidelines in the practice where the portion is written off, whether you're taking care of a team member or a family member, that is always the doctor's option to do.
Got it. But in terms of, let's say I have insurance with somebody in the practice is not contracted, but they are going to file the insurance?
We still have to follow the guidelines. You cannot write off the portion and then submit to insurance, because that is still considered fraud, whether you are in network or not.
So you have to disclose what you charge the patient.
Yes, you do.
Correct. In other words, if you
Yes.
didn't collect, if you didn't collect anything from the patient, then that needs to be disclosed when you file the claim. Just
Correct.
tell the truth.
Yeah, including working on
What
team
a
members.
concept.
Yeah, including working on
Got it.
team members. If you're going to do treatment, it has to be disclosed on the claim.
All right, next question. Since the beginning of 2018, so the last 2 weeks, it seems that insurance companies are not getting the narratives that I write. I've talked to eClaims, and they can see the narrative on their end. And the question is anyone finding the same? So it's MetLife, Anthem, Aetna, not just one company. So Pam, you run across that anywhere?
No, I have not experienced that. A lot of times, if they're not receiving the narrative, then they're not receiving the claim. So this is the first. Not saying that it's not happening, but it's the first that I've heard.
Got it. Okay. As I mentioned earlier in the broadcast, we have recorded this webinar today, so it'll be rendered and posted this afternoon on crowncouncil.org. And if you were registered for the webinar or you're on the Crown Council email network, you will get an email with the link to this webinar. So any team members that were not able to watch today can go back and watch this genius information that we provided today. All right, the next question. At the beginning of the webinar, you mentioned that some insurances are not going to have some plans. Okay, so yeah, did you say Delta Dental Premier? Yeah, so what I mentioned was that at this current time in many parts of the country, Delta Premier is going away. It may not be immediately canceled, but in many parts of the country, they're making moves to gradually phase out Delta Premier. It's particularly pronounced on either coast. In California and on the East Coast, there are some aggressive moves being made to do away with Delta Premier altogether. If you're in the middle of the country, you may not have experienced it yet, but you can rest assured that if it's happening on either coast, it will be coming to a town near you soon. So there's a lot of practices that are only Delta Premier providers, but not a Delta, don't provide any other type of or services for Delta. So it is creating some issues. So if that hasn't hit your area yet, it's coming, and there's a lot to learn from what's going on either coast. So as I mentioned, we'll have a webinar coming up shortly in the next 30 days on going insurance free. So it will contain some great information from practices that have gone through that process, whether they've decided to go 100% fee for service or have decided to drop different insurance plans, how they went through that process successfully so that they can continue to grow their practice, their profits, and their profitability. So stay tuned for that. That is a big topic, and certainly one that's gaining more and more interest. Next question, back to discounts. We give patients a 10% discount if they pay up front all of the fees for their procedure. Is that okay, Pam?
With a skill that a system that we teach using the Easy Pay form, a lot of practices that we work with will extend a 5% or a 5% or up to 10% if fees are paid in full. Most are doing this if it's fee for service. If you are extending this to patients that you are taking their assignment of benefits, the same rule apply as what we mentioned before. It has to be disclosed on the claim if you are going to give them a discount on top of what has been submitted.
So bottom line with all of these is whatever you charge the patient has to be disclosed. If you give them a 10% discount, you have to disclose that on the insurance claim. If you're Whatever you do, it just has to be disclosed. Otherwise, it can be construed as being insurance fraud. Next question. Comprehensive perio exam is once a year or once in a lifetime. Which is it?
Okay, I wish it were once a year, but it's not. This is a code that is in the family of the D150. You can use D150 more frequently than you could, like 3 years. Then it's the same as the D180. It's in a lifetime unless their insurance has changed. So you won't be able to use this code like a periodic exam code once a year.
Okay. Let's see, I'm not sure whether I understand this and how to figure that out without calling each time. I'm not sure I understand that question. I have to come back to that.
Okay.
Next question, how often are we allowed to do a fee schedule analysis during the year? Okay, so let me explain the fee schedule analysis thing. So that information is updated typically once a year. So basically, where the information comes from, if you request a fee analysis by emailing spencer@crowncounsel.com, you'll get a report that basically shows what the fees are for different procedures in your marketplace by percentile basis. So that information comes from two different sources. One, it comes from insurance claims, information that off of insurance claims that are submitted from your market area, as well as survey data that goes out to dental offices that ask them about their fees. So that information is updated once a year. So for example, if you did that fee schedule analysis and update this month in January, then you would do it again next January. So there's, in other words, the data updates every year at the end of the year. That makes sense. So doing it once a year makes sense, as well as making sure that all of your fee schedules are updated every year when, if you're contracted, when the insurance companies come out with their updated schedules. We've had, I just had a conversation right before this call where we discovered in one particular market where the fees actually increased, where the insurance reimbursement fees increased from the year before, which I was astonished. You don't hear that very often, but they actually increased. So they're only going to reimburse you for what you submit for the claims. You always want to make sure those fee schedules are updated. Next, where on the claim is the discount disclosed? Pam, you want to address that?
Yes, in the same area where it's labeled notes. This is where the narrative would go as well. So it's right there in the notes section. It's not quite the bottom of the claim, but it's on the left side, like right in the middle of the claim. And it says notes, and you can just disclose your notes right there.
Next question, when we send the disclosure to the insurance on discounts, so if they've discounted it and they send that, if they've given a discount, are there any outcomes or changes that will be made regarding the fees on our contract?
Just by when disclosing discounts?
Yeah, in other words, I think I understand this question. So if I gave a patient, if I discounted their fee for whatever reason, is that going to impact the contracted fee moving forward? My understanding is it will not. It might impact what the insurance company reimburses on that particular claim, but it wouldn't change the contracted fee. Is that ongoing?
Yeah, I would agree with that. I don't feel like that they would make a across the board judgment because of a couple of claims where you've disclosed that.
Got it. Okay, so Pam, the previous question is on the perio code. I guess the comprehensive perio evaluation.
Mm-hmm.
So the question is on that. The question is, how do you figure out if you use that code unless you call the insurance company? How do you decide whether you're going to use that comprehensive perio code for the exam?
That has to be like a qualified patient. A lot of times when you are talking to a patient, you do an emotional exam, you actually will know that before even looking in their mouths. If you have someone that smokes and you know that they are a perio candidate, that would be the qualifying patient for that, to do a periodontal exam. The payment is slightly higher than a D150. Like I said earlier, you won't be able to use it as often, but it's for qualifying patients that you know that they are perio patients. If they have gum disease, where if they smoke or have diabetes, some of the qualifying areas that would put them in the category of a perio patient. That's when you would use that. Now, you still have to make sure that you submit the proper documentation when submitting with this, using this code, which is your perio chart and the necessary x-rays.
Got it. I'm adding a little resource here, Pam, at the very end, because I think this is needed. So here's the last question. If a filling is downgraded, are we allowed to still charge the patient for the difference between, I guess, what their insurance covers and what we actually did? So if a filling is downgraded to a lesser filling, are they still allowed to charge the patient for the difference? Does that make sense?
Yes, absolutely. When getting a breakdown of insurance savings, that the insurance company will let you know. You have to ask the question, because they won't tell you. Do we downgrade? What do you pay towards that? And the balance you can bill to the patient, where the patient will pay the portion, so you don't have to write it off.
Got it. Perfect. Okay, Pam, you're awesome. Thank you for those. A lot of questions. Obviously, there's a lot to know about this. And for more answers to your questions, specific verbal skills questions, coding questions, anything like this, you are more than welcome to email answers@totalpatientservice.com. That's your digital hotline. And someone on the Total Patient Service team will respond to that. We'll find the most qualified person on the team to respond to whatever insurance coding or verbal skills questions you have. All of you know that at the Total Patient Service, we have created the resource for case presentation excellence and patient service. So there's a lot of resources there in terms of seminars and free resources that are on the website. So please make sure you take advantage of that, as well as your fee schedule analysis. And if you'd like the list of third-party payment resources, you can email Spencer at crowncouncil.com, and he will shoot those right back to you. Thanks for joining us on our webinar today. We've covered a lot of information. As I mentioned, coming up in the next 30 days, we'll do a very special webinar on going insurance free, or dropping insurance plans, if that is something that you've considered in today's very interesting insurance environment. So stay tuned for that packed seminar. Look forward to having you with us again for a Crown Council webinar. Have a great day, and again, thanks for joining us.